75%. Now, what if I told you that's the percentage of dizzy patients you could correctly classify using, well, nothing more than the clinical history? Yep, no scans, no complex tests, just asking the right questions. That's the power we're going to tap into today.
Hey there, and welcome. So in this explainer, we're going to rethink the very first minute of taking a history from a dizzy patient. Now, dizziness is the third most common complaint in primary care. And you know what? It's also one of the most misdiagnosed. Our goal today is to replace that old, often unreliable approach with a brand new framework, one that brings clarity and precision right from the very start.
All right, so here's our roadmap. First up, we'll confirm why history really is the cornerstone of diagnosis. Then we're going to dismantle the single biggest pitfall in the dizzy history, what I call the symptom-quality trap. After that, I'll introduce you to a powerful new framework. It's called TiTrATE, and we'll really focus on its most crucial element, which is timing. And finally, we'll pull it all together into 4 simple, totally actionable diagnostic categories. Sound good?
Okay, so let's dive into this first principle. Before we get to any fancy maneuvers or imaging, we really have to appreciate that the most powerful diagnostic tool we have is, simply put, the conversation with our patient.
And this chart, this really just lays it all bare. Look at that huge slice of the pie, 70 to 75%. That's pure clinical history. A targeted exam? Okay, that adds another 10 to 15%. But look at what's left for imaging and all that vestibular testing. It's a tiny sliver. So the crucial point here really is that the game is won or lost in those first few minutes of just talking to your patient.
So if history is everything, we have to make sure we're asking the right questions. And that brings us to the central myth we really need to bust, the single biggest error that sends clinicians down the wrong path from the very start.
I'm talking about this question, the one we were all taught to ask. It feels so logical, doesn't it? We're just trying to put the patient's experience into a neat little box. But this seemingly innocent question is precisely where things go wrong.
You see, asking about the kind of dizziness funnels us into these 4 classic, but honestly, deeply flawed categories. We immediately try to sort the patient into one of these buckets: vertigo, presyncope, disequilibrium, or lightheadedness, assuming that each bucket maps cleanly to a cause. Well, it doesn't.
In fact, this entire line of questioning is a diagnostic dead end. It is such an unreliable starting point. It creates way more confusion than clarity, and believe me, the evidence for abandoning it is just overwhelming.
And here are the 2 big reasons why it fails. First, you've got inter-visit instability. A patient will describe their dizziness as vertigo on Monday, and then call the exact same feeling lightheadedness on Thursday. Their vocabulary just isn't consistent. And second, and this is even more important, there's a profound quality-cause mismatch. For example, patients with vestibular migraine or even orthostatic hypotension frequently report true spinning vertigo. So the symptom quality, it simply does not correlate reliably with the underlying cause.
So, if we're going to throw out that old first question, what do we replace it with? Well, we replace it with a structured, reliable framework. It's time to meet TiTrATE.
The T stands for timing, and this is the new anchor for our entire history. Is the dizziness constant, or does it come in episodes? If it's episodic, how long does each spell last? Seconds? Hours? This is our new first question.
Next is TRA for triggers. So what reliably provokes an episode? Is it rolling over in bed? Standing up too quickly? How about walking down a supermarket aisle? These specific triggers are incredibly powerful diagnostic clues, and we'll explore them in much more depth in our next explainer.
Then we have A for associated symptoms. Here we're listening for distinct clusters. Does the dizziness come with hearing loss, a headache, double vision? These symptom packages help us narrow the differential diagnosis a lot. Okay, and only after we've established the timing, triggers, and associated symptoms do we then move to the T, the targeted examination. And notice, this comes after the history. Why? Because the history tells us exactly which tests will be the highest yield.
And finally, E is for evaluation. This is where things like imaging and formal vestibular testing come in, but they are used very selectively. They're meant to confirm a diagnosis we've already pretty much formulated from our history and exam, not to go on a fishing expedition.
All right, let's really zero in now on the most important part of this framework, especially for that first minute of the consultation. For the rest of this explainer, we're going to focus on that first, most critical component, timing. This is the paradigm shift right here. Duration,
not quality, is the key to organizing your thinking.
And this table just brilliantly illustrates why. I mean, look at this. Just by asking how long does an episode last, you immediately slash the differential. Are the episodes lasting for seconds? You're already thinking BPV, that's benign paroxysmal positional vertigo. Minutes? Well, that points towards vestibular migraine or a TIA, a transient ischemic attack. Hours? Think Meniere's disease. And what if it's continuous for days? Your mind should go straight to vestibular neuritis or a posterior circulation stroke. If it's been going on for weeks to months, you're now considering chronic conditions like PPPD, that's persistent postural perceptual dizziness. You see? This one question brings instant structure to a seemingly chaotic presentation.
Okay, now let's take it one step further. We can actually combine timing with the very basics of triggers to create a simple, elegant map that will let you categorize nearly every single dizzy patient you see.
This is it, the 2x2 map. All you need are two questions. First, is the dizziness continuous or episodic? And second, if it's episodic, is it spontaneous or is it triggered? That's it. So a patient with continuous dizziness for days has acute vestibular syndrome. You should be thinking neuritis or stroke. Episodic dizziness triggered by a position change, that's triggered EVS, think BPPV. Spontaneous episodes that come out of nowhere, that's spontaneous EVS, think migraine or Meniere's. This simple map is your new starting point.
So the crucial point to take away today is this. Abandon asking what kind of dizziness is it. Instead, anchor your history on timing and triggers. Use the duration of each episode to rapidly narrow your differential diagnoses, and use that 2x2 map to collapse all of dizziness into 4 simple, actionable categories right from the start.
So now that you can categorize your patients, the next step is to nail the specific diagnosis. And in the next explainer in this series, we're going to dive deep into triggers and associated symptoms. We'll give you the tools you need to move from one of these 4 big buckets to a precise working diagnosis.
Now, mastering this new approach does take practice. To help you integrate it, we have more resources and clinical tools available for you on our website. If you found this paradigm shift helpful, please subscribe so you don't miss our next explainer on triggers and associated symptoms. Thanks for watching.